Does my background look good? Am I good?
Are we getting in professional mode?
It's fine. It's more. It can be more
Oh
relaxed.
man, unlocked.
Locked and loaded. All right. So first, you just introduce yourself.
Okay.
Um.
My name is Leslie. I am a psych nurse practitioner. I have been a nurse for, 22 years now. I started out in nursing wanting to be a pediatric nurse. I wanted to take care of children. And during my first nursing rotation, I realized that I did not want to do that. And I almost dropped out of nursing school. Um, and then I was so irritated when I had to do my psychiatric nursing. I'm like, why do we have to do this? And I went and I absolutely loved it. Um, but I didn't start out in that because, for one, I had a lot of nurses tell me not to do that, where I can get more of a medical background and first. So I still try to do pediatric nursing for a year, still hated it. Love the kids. It's just wasn't the environment for me. And then so I went to OB nursing. So I worked probably for about 15 years on a women's service floor. Stayed there for a while, had a good group of nurses. But I just always wanted to go back to psych nursing. And so I finally realizing, that I've been a nurse for 15 years and still had 25 more years of nursing to do, I decided to take that leap and went to psych nursing. And then my first day on the floor, I absolutely loved it. I worked on an adolescent unit. It's an inpatient unit at the county hospital. The kids were 13 to through 17. And then I realized that's the pediatric nursing I wanted to do. I also worked with adults as well, but my main unit was working with children.
Nice.
So I did that. As soon as I started there, I went into decided to go back and get my master's to be a nurse practitioner. So that's where I am now. I am
Let's
been
go.
doing this for 2 years. And I really love it. My main regret is I didn't do it earlier. But I'm working telehealth only, and it's an IOP program, so it's like a step down from inpatient, step up from outpatient, step down from inpatient. So it's like this middle ground where they're not quite ready to just do therapy once or twice a week. They do therapy 3 to 4 days a week with group therapy, and then they meet with their individual therapist once, and then they meet with psychiatry, which is what I do, which is med management, and I do a little therapy as well. So they meet with me if they do feel like they need medication or need their medications adjusted. So that's what I do now. But before that, I was at the county hospital.
Mm-hmm.
Yeah.
Nice. Okay, so you walk us through what your day to day to the hospital would look like.
At the county hospital.
Yeah.
Yeah, so I think it's really cool that you picked the inpatient county hospital, mental health, psychiatry hospital in general as your place, because it's a place that is, has some multiple layers to it.
Yeah.
There's different types of mental health facilities that are inpatient, so you can have private places, and then you can have the county hospital like I worked in, and then you can also have a level of a state hospital. So county hospital is a lot like the private, but we just deal with more of our Medicaid patients and patients that have difficulty with payment, but that's not all we do. And so from a county, we get funded from the government, and then you also have the state hospitals, which patients they end up when they need a little longer stay. So at the county hospital, which there's a couple in the state of Texas, and each state, by the way, has their own laws for how inpatient hospitals are run. But a day-to-day, as in a nursing standpoint, what we do is, first of all, the patients that are there, they're usually there 5 to 7 days, give or take, sometimes less, sometimes more, just depending on what's going on. So on an adolescent floor, there's usually the most kids that we could have would be 20. And so sometimes we'd have a little as 5, but most likely we have 20. Each unit, including the adult units, are co-ed. So there's males and females both. And what they do is they usually have medication that they get morning and night if they're on medications. They have group therapy that they do. They'll do that twice a day. And then they'll also meet with a social worker, which is also a therapist. And they'll meet with them daily. And they isolate what they do because they help run group therapy, and they help with all the social aspects of it. Of, like the main thing is we want them to get situated and stable where they can go to their outpatient treatment, because we don't want to have to keep them longer than they need to. Being in a psych facility is for their safety, but we also, we take away pretty much all of their, they can't make phone calls when they want to make phone calls. They get their cell phones taken away. Sometimes they don't even get to wear the clothes they came in with, just for safety reasons. So we want them to be in that environment just as much as where they can. The goal is to leave. And so that's where the social workers come in, where they can make sure they have all the resources and stuff they need to be successful for when they do leave. And then mainly they have a lot of free time too, in between, so they're not always doing therapy. And the main thing is we're keeping them there in a safe environment until we can get their medication stabilized. The thing with psychiatric medications is a lot of, like for medical reasons, you give medications and people feel better right away. But with mental health, anything, we call it psychotropic medication. Sometimes it takes a couple weeks to get really the full effects of it. So they're there to get stabilized and be safe until we can get them there. So really, we're just giving them medications, monitoring. When you have a group of mental health patients that are there all for different reasons, they can be there for their having a psychosis episode. It can be their first time, or it can be the 20th time, or they're severely depressed, or just anger management, or a lot of other things. So you get a group of people like that. So a lot of times it's just managing the situation, keeping things calm and keeping everybody safe is our main goal there. So as a nurse, it's kind of different going from medical nursing to psychiatric nursing, because you kind of shift what you're dealing with. But yeah, so that's kind of a main day to day. Do you have any specific questions for that? Or did I cover it?
I mean, you did pretty well. I mean, pretty good at that, but like how can you make sure that these patients are getting like correct treatment instead of just just there for nothing, you would say?
Yeah. So there's definitely a lot of regulations involved, because we're basically, some patients come in voluntarily. So they come in, everyone usually goes in through the emergency room. So they either come in and say, hey, I'm in crisis, I need help. Every patient gets evaluated. They usually come into the emergency room, and then they'll come up to psychiatry, and they'll get evaluated by a psychiatrist, who will either say, hey, let's hold you for 24 hours and reevaluate, or, you know what, I think you're safe, let's get your meds that you need and get you set up for outpatient treatment. Or they don't want to be there, and we're like, no, you need to be here. So they either have gotten brought in by the police or a family member, and they're in danger to themselves or someone else. And so in those situations, they're there against their will. So it gets a little tricky. The intentions are to keep them safe, but at those times, they may not feel like that. Even when they get discharged, they may not feel that way.
Yeah.
And we have to have outside facilities that come in and make sure everything is getting regulated, especially when you have somebody that you're pretty much keeping against their will at times. So there's, for the nursing standpoint, there is a facility called JACO, and they can come in as a surprise visit. Usually they come in every couple of years, but we never know when they're coming. So that's the way where we know we need to keep everything regulated and everything safe for these patients. And so there's definitely monitoring going on.
Cool.
If there are things that we need corrected, we correct it, and we have to correct it in a certain amount of time.
Cool. And of course, it's important to keep like the patients safe. But what are some things to keep like the nurses safe? Is that something that
That
you're
is a great
struggling with,
question.
or
That is also like safety isn't 100%, so that's kind of why a lot of people don't get into it, because it is a hazardous job. We actually, at the hospital, you get hazard pay, like extra pay per hour to work in these places. Usually, and I honestly would tell other people, I felt more safer working in psychiatry than I did when I worked the medical part of the hospital, because we have all these safety measures in place. We have security that's trained for psychiatric patients. So there's always at least 1 or 2 security guards on hand that we can call. And then we also have at the county hospital, we have a police station there. And so if there's something really bad going on, we can call the police and have their presence there as well. We also do annual training. It's called, can't think on top of my head, but there is like a program that we were last doing, but there's different programs that different hospitals use. And it's mandated by the state too. Therapeutic options. There you go.
There you go.
What's the last thing we were using, but it kind of walks you through all these different scenarios of like, you've done all your therapeutic interventions to keep them from getting angry, but mental health is very unpredictable. So if you do get into a situation where there's a violence happening, we have all these different ways to kind of help. So everyone's trained with it. And then we have places where, like if we're going off the unit with them, you can't go off the unit by yourself. You have somebody with you. And so, and then it's a lockdown unit, so people can't come in either. So I always felt more safer there. And like you get used to it and you get trained to, like, when someone is kind of angry, you learn how to de-escalate that anger pretty quickly. But a lot of times, again, how I said, we have different patients. Sometimes you get one patient mad and then it brings someone else, and then there's multiple. So that's when it gets a little bit dangerous. But then again, we're always kind of ready for those situations.
Good. And like, how many people do you have working with you, like nurses or techs or whatever?
Yeah. So that is kind of an ongoing problem, and that kind of goes back to like it's a dangerous job, and so sometimes we have a lot of turnover, and ideally, so for the adolescent unit, for example, we would have at least 2 nurses at all times, and then we have a tech has to be on the floor at all times. Usually we'll have multiple techs, because we'll have some patients that, and that's another safety issue that we have, is if we have a patient that's a little more violent, there'll be kind of a 1-to-1 patient where someone's always kind of watching them for our safety and the other patient's safety. And so there's always has to be at least 1 tech and 1 nurse on the floor at all times. Is that enough? Probably not.
Yeah.
But and it kind of goes back to, like, in a medical unit, you have you can kind of see how, based on what a patient's diagnosis is, how many nurses you need.
Okay.
It's a little more predictable. Psychiatry is not predictable. There's no way really to predict how the night's gonna go. You can have 10 kids and you're like, oh, we only need 1 nurse and 1 tech, and those 10 kids can all start a riot.
Yeah.
Or you can have a full group and they all have aggressive backgrounds, and it's the smoothest night ever. So it's really hard to kind of predict that. And unfortunately, especially being in the county hospital, you're staffed based on numbers in patients, so you don't always have what you need.
Yeah. What else we got? Uh, so it's definitely a job that is there definitely needs to be more psych nurses, correct?
Yes.
Yeah.
And on that note too, I another reason why I like you bringing attention to it is we need like good nurses in psych. It takes a special kind of nurse, I would say, to be a psych nurse because it is dangerous. It You have to be non-judgmental, like these people are here for your care, they're not in trouble, and it's hard to sometimes there's still a mental health stigma within the workers. And it takes a lot of education, and my goal is to at some point teach at the school where I can kind of help get like there's still so much mental health stigma out there even within the medical community.
Mm,
And so a goal of mine is just to kind of help with that and get better care because there's definitely needs to be better care in mental health.
perfect. Cool. I think that wraps up most of the topics, questions.
Okay. um yeah, so like kind of in summary, each state has different requirements that they have for what requirement for patients to get in,
Mhm.
how long you can stay, and things like that. So in general, in Texas, we have a lot more in place than some other states do. So it is a very broad issue. So I'm really glad like you're putting it like what actually happens in mental health problems. I think a lot of times from movies and things like that we get like this how we view how a mental health hospital is when it's actually come up a long ways, and it's really helpful for people and a safety protection for these people, and they're not in trouble. um, they are there to get better,
Mhm.
and I love being able to help my community.
Love that. Love that. Um.
Thank you for talking to me about
Uh huh.
this.
Thank you for letting me
Yeah.
interview you. I wasn't recording that whole time.
Okay, are you serious?
No, I'm joking.